Okay, welcome to this podcast for Chapter 11. We will be covering behavioral health services. Um, that might be confusing. We're talking about mental health here. So the title of the chapter is a little confusing maybe for some. We have 15 pages in the textbook. Even though there are 15 pages in the textbook, we have 30 slides because we have some important information to convey here. Team 7 has been assigned to do a videotape case presentation for the case at the beginning of this chapter. DL is a 42-year-old with chronic paranoid schizophrenia. The patient now exhibits tremors, but again, Team 7 will be presenting this case, so I'll leave it at that. I would also like you to focus in on Table 11.1, which are these behavioral or mental health conditions in persons who are duly eligible. That means they're eligible for both Medicare and Medicaid. So there are, let's see, 5 learning objectives here that we'll cover. Again, I had mentioned before that Team 7 will be discussing this patient with paranoid schizophrenia. So I'll leave that. Beginning with the global burden of the behavioral health. Behavioral health problems are a significant global public health issue. 14% of the global health disease burden is due to mental disorders. 3 measures to determine global burden of disease are disability-adjusted life years, years of life lost to premature mortality, and years lived with disability. Now, that might be confusing, that terminology, but suffice to say, if you live 20 years and you have no disability, you would have 20 years. Now, if you have a disability that takes away some of your function, like 50% of your function, instead of having 20 years left of your life, you would only have essentially 10 disability-adjusted life. You would take the functionality 0.5 and multiply it times your thought of what you have left in life. So it would be less than the total of 20. Same with years of life lost to premature mortality and years lived with disability. Individuals with behavioral health problems also endure more social isolation, poorer quality of life, and increased mortality. Less than 70% of all World Health Organization countries have mental health problems. So there's a lot of need out there, but little help. World Health Organization estimates 25% of all patients using a mental health service suffer from at least one mental, neurological, or behavioral disorder. Many disorders go untreated. Costs of treatment for behavioral health problems globally and in the U.S. The costs of behavioral health problems will more than double by the year 2030, from about $2.5 billion to almost twice that in 2010. In 2030, I'm sorry. Spending on behavioral health services accounted for about $172 billion, and prescription drug costs account for about 28% of the costs. So it's a significant chunk of change to take care of these problems globally and in the U.S. Why treat behavioral health disorders? There's an increased risk for developing many physical illnesses, major risk factors for communicable and non-communicable diseases, major risk factors for unintentional and intentional injury, and health conditions increase the risk for behavioral health problems and complicate diagnosis and treatment. So there's been a lot of attention to this in the news with people with behavioral disorders taking out their anger, frustration on other people with guns and such. So this is something that's in the forefront of the national news. Co-occurring disease disorders, more instances of premature death and higher rates of disability for patients with co-occurring disorders, like you might have paranoid schizophrenia and some kind of dementia. It just makes it more worse. Interaction between co-occurring disorders with regard to prevalence, disease severity, and causative factors not completely understood. For every dollar invested in drug treatment, $7 are saved in health and social costs. So a lot of proponents of behavioral health services point to this particular bullet. Again, for every dollar invested in drug treatment, $7 are saved in health and social costs. Criminal justice setting de facto treatment facilities, 1 in 35 adults in the U.S. was under some type of correctional supervision during 2013, and approximately 1 in 51 was on probation or parole, and an estimated, let's say, 7 million people were in adult correctional systems in 2013. U.S. state and federal prisons held an estimated 1.5 million inmates. Local jails had about 1 million individuals. An estimated 5 million persons were on probation or parole, and more than half of all prisons and jail inmates have a behavioral health problem. So you can at least start to get your arms around this problem. Criminal settings, de facto treatment facilities continued. There's mercy arrests are common. So they'll arrest somebody with like paranoid schizophrenia and put them in jail just so they don't hurt themselves. Psychiatric beds in community hospitals are often unavailable. Many state residential treatment facilities have been closed. That is quite a bullet there. Many state residential treatment facilities have been closed because many states find them costly. They feel like, well, if they give them the right medication, they can take care of themselves. That's debatable. Only 1 in 3 state prisoners, 1 in 4 federal prisoners, and 1 in 6 jailmates who have had behavioral health problems receive this type of treatment while they're incarcerated. Epidemiology of mental disorders. Globally, 400 million suffer from depression, 21 million suffer from schizophrenia, 60 million suffer from bipolar disorders, 91 million are affected by alcohol use disorders, 15 million people are affected by drug use disorders, and 450 million are affected by traumatic brain injuries, dementia, and other neuropsychiatric disorders. So you can see quite quickly that if you were a mental health or behavioral health pharmacist, you would have your hands full with people with depression, alcohol use disorders, and people affected with traumatic brain injuries. National epidemiologic studies include the epidemiologic catchment area. A catchment area is a particular geographic area of the country, and they focus in on that catchment area. For example, it might be part of New York, like Western New York. There's National Comorbidity Survey, where you look at people that have more than one mental health problem. The National Comorbidity Survey Replication Study. There's implications for pharmacy, behavioral health, and public health practice, education, and policy that have emerged from each of these 3 studies. Now, there is a IRAT that comes from this particular slide that you need to know. You need to know that the epidemiologic catchment area study found that 20% of the study sample had a mental disorder during the previous 12 months. So again, that first bullet, the epidemiological catchment area, that a major thing that you're going to find when you read the textbook is that it found 20% of the study sample had a mental disorder during the previous 12 months. Moving on to the next slide, vulnerable population. We're focusing on homeless individuals here. There's an estimated 500,000 people are homeless in this country. 18 individuals out of about every 10,000 people. 60% live in shelters. 37% are families. Almost 25% are children under the age of 18. 30% have serious mental disorders and 70% have physical disability. 38% report an alcohol dependency problem. 26% report other drug use, abuse problems, and 37% of individuals have chronic substance abuse issues. Continuing on, there's the chronic hopelessness. About 100,000 people are chronically homeless. Almost 2/3 live in unsheltered areas like under bridges, in cars, in abandoned buildings, campsites. More than 1 in 10 homeless adults is a veteran, which is a big issue. Approximately, well, when you're talking about vulnerable populations that are duly eligible, that means they're eligible for Medicare because they have some kind of disability, but also they have Medicaid because they don't have much money, period. So they're duly eligible. There's approximately 10 million individuals that are duly eligible during fiscal year 2010. Among the oldest, poorest, sickest, and most disabled individuals. So if you're talking about a duly eligible person, you're talking about somebody who's really has some issues and really needs some care. 59% are 65 years of age or older, 55% are women, more ADL limitations than those under 65. They have behavioral health problems, intellectual disabilities, and related conditions more common in populations under the age of 65. 14% account for 36% of the Medicaid expenditures and for 33% of Medicare spending. 75% of persons who live in nursing homes are duly eligible. So 75% of the people who live in nursing homes have both Medicare and Medicaid. So a question, an IRAC question that comes from this slide is that you need to know how to describe individuals who are duly eligible, and that is that 38% have cognitive impairments, 22% have multiple physical impairments, and 23% are institutionalized, all three of those. Landmark reports and legislation. There's the Joint Commission on Mental Health and Illness. There's the Community Mental Health Centers Act. There's Title 18 and Title 19 of the Social Security Act of 1965, which is basically Medicare and Medicaid. There's the Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act, and the Patient Protection and Affordable Care Act. There's a report of the Surgeon General and another report, Achieving the Promise. When we're talking about mental or behavioral health service delivery and the community pharmacist, which kind of goes to the case for this chapter that Team 7 will be covering. Medication adherence is a major issue for persons with chronic behavioral health problems. So if they have like paranoid schizophrenia, they may have problems adhering to their medication regime. Reasons for non-adherence: lack of insight into the severity of the disorder. They may be foo-fooing it when it really is an issue and it does affect their medication adherence. There's difficulty paying for the medications. There's an unstable housing and support systems, and there's lack of access to care. You need, as a community pharmacist, to improve adherence, which may decrease rates of hospitalization and decrease utilization of acute medical care services. The role of the community pharmacist can improve adherence through counseling and support. There's evidence-based practice, EVP, treatment guidelines. We're talking about integrating individual clinical expertise with best available external clinical evidence from systematic research. Treatment guidelines can be evidence-based or expert consensus guidelines. So this is extremely important. It won't be on the IRAT, but you need to know there's a difference between evidence-based and expert consensus. There's some things that we have randomized controlled clinical trials, we have science that can prove that something is the best way to go, whereas expert consensus is, this is kind of a fuzzy area where there's no science to prove that this might be the best way to go, but there's a consensus among psychiatric professionals that that is the best way to go. Evidence-based treatment guidelines provide treatment recommendations established by the clinical literature. Expert consensus guidelines, on the other hand, are developed from experts in a particular area based upon their current practice, which may or may not be informed by the clinical literature. So a lot of experts get together at a conference and decide what might be the best way to treat chronic paranoid schizophrenia. Two examples: the American Psychiatric Association practice guidelines and the Texas Medication Algorithm Project. Community pharmacist is in a unique position to authorize specialized medication therapy management services using these guidelines. There's open access to behavioral health drugs. Indiana is an example. Preferred drug lists, PDLs, are used by Medicaid programs. So like if you're in Indiana and you want to use something for somebody with a mental health or behavioral health problem, you have to refer to these preferred drug lists. There's a number of arguments for preferred drug lists: costs, results of clinical trials, changing practice. The state of Indiana, their Mental Health Quality Advisory Committee, this is a subcommittee of the Indiana Drug Utilization Review Board, open access to behavioral health drugs without PDLs, and quality of use edits. So in other words, if you're in a particular state, Medicaid has a list of drugs that can be used for people with Medicaid to get drugs. You can't give them something that's not on one of these lists. And you may see that on your IPPEs. Mental health teams and the role of the pharmacist. There's a multi-disciplinary team, often with a clinical psychiatric pharmacist. The role of the clinical psychiatric pharmacist: medication management, including the initiation and adjustment of therapy, laboratory monitoring. A lot of these drugs, like clozapine, will cause a reduction in white blood cell count, so you have to keep an eye on that. Authorization, monitoring of prescription refills. If they don't get their prescriptions refilled, you know that they aren't taking it right. Interaction with the treatment team and their physician extenders. So I think Dr. Rebecca Wade will be teaching you some of this next year. She's a clinical psychiatric pharmacist. She's board certified in psychiatric pharmacy. Prevention and promotion. Based on a triad concept of prevention: primary, secondary, and tertiary Behavioral health promotion activities enhance an individual's confidence, self-esteem, and sense of well-being. It's found on a variety of settings. Healthy People 2020, for example, is a 10-year national objectives, integration of mental health objectives into pharmacy practice and education. Informing the Future is an important white paper, provides a framework for integrating health, behavioral health, and public health. This is something you can read about in your textbook. An IRAC question comes from this slide. Essentially, to measure global burden of disease, which you need with behavioral health problems, you look at disability adjusted life years. We talked about that on one of the first slides. I think it was the fourth slide, but we're talking about it here again. How do you measure the global burden of disease? That's with DALY's, disability adjusted life years. And it comes out on when you're talking about this, these health promotion activities and how they can lower disability adjusted life years. The role of the pharmacist in rural America, frontier health professional shortage area. If you look in areas that are very rural, like, I don't know, Nevada, Appalachia, there's a shortage of professionals. 90% of the U.S. defined as rural. 20% of Americans live in rural areas. So a large portion of our country is described as rural, like Nevada, but only 20% of Americans live in those areas. Medically underserved areas occur in almost every state in the country. Health promotion is a growing service area for rural pharmacy practice. Recommendations to assist in rural pharmacy practice: transition from a product-based reimbursement payment system to a more realistic reimbursement system. There's exemption to the antitrust law, Medicare Part D, and third-party contracts, and expand Medicare definition of non-physician practitioners in rural health centers to include clinical pharmacists. There's a real but quite a shortage of practitioners in rural areas. In fact, there are a lot of grants to help students get through medical school, but as part of getting this grant of money, they would have to work in a rural area for a certain number of years. That's part of their bargain there. ERISA and pharmacy benefit managers. ERISA stands for Employee Retirement Income Security Act of 1974. Approximately 55% of employees in firms with 200 to 999 workers are self-funded. Pharmacy benefit managers may fall under ERISA as a fiduciary. That means they have an obligation to take care of these people. Must operate in full transparency and full disclosure. They act in the best interest of its health plan beneficiaries. Recent state and federal court cases addressed alleged breaches of PBM fiduciary duties. The federal law preempts state law, which creates regulatory gap. The one thing I want you to understand here is that pharmacy benefit managers are under a lot of scrutiny. So, for example, they say that we've done some kind of study and we don't find that this drug will cover this drug because maybe a much less expensive drug is just as good. A lot of folks get mad. They want proof that this is true. And so the states have gotten involved with these transparency issues. So a lot of these companies have had to publish their studies online for people to read through. Now there's an IRAT that comes from this particular slide. And I want you to know that the ERISA Act of 1974 hinders the regulatory ability of some state governments. So even though some state governments would like to do things like force PBMs to do certain things, they can't because of this ERISA. Their obligation, this ERISA was to protect people's retirements, not to protect them, the information they get on their benefits for health, so to speak. So sometimes there's some friction there. So the ERISA hinders the regulatory ability of some states on some issues. That's the point. Legal and ethical issues, there's the right to refuse treatment and informed consent issues. There's coercion. There's regulation of the patient therapist relationship. There's confidentiality. There's professional licensing laws. There's resource limitations or rationing of health and behavioral health services. There's denial of service, and there's the Tarasoff rule. A lot of these issues I won't go into a lot. You won't be tested on, but be advised that when we get into the ethics section in next semester, which is part of the communications course, we'll be talking about these a lot more closely. Certainly if you take my ethics elective, which you can take in the second or the third year, we'll get into these. Implications for pharmacists and pharmacy practice, growing collaboration for community pharmacists and psychiatric clinical pharmacists among health providers. There's a retooling of pharmacy education to address these new rules. Help future pharmacists get involved in community centers, epidemiologic and disease surveillance, and health information technologies. Further, there's federal and state policies need to be aligned to promote collaborative practice, which we don't have too much in this state. Increased involvement with policy work groups to bring pharmacy concerns to policymakers and legislators. So on Pharmacy Day, go to Albany with other professors and students to discuss new legislation to help these endeavors. And there's the response to this case scenario that Team 7 will be covering. I don't want to steal their thunder, so we'll just move on, and that's the end of this podcast.